Yes, Mustafa, thank you very much for the introduction. Manos and Manos, thank you very much for having me again here in Athens. I'm very happy to be here, and I think we all can already realize you did a very great job again. As we've heard right now, it's going to be all about, or mostly about, the horizontal instability and how we can address this. We already tried to go a little bit into this, but we will see that it's even more if we get closer and closer. If we talk about the indication for AC joint repair, the question is there also a role in indication, getting the right indication for horizontal instability? Do we look at it before we decide whether this patient has to undergo surgery or not? And also, if we choose our techniques, do we try to address the horizontal stability or not? I think these are the key questions in 2020, and I think we have to answer this correctly. I always like to show these pictures because it shows how it all happens. Sergio Ramos said it was just a little contact. Probably it was a little bit more what Mo Salah had in the Champions League final in 2018. And you can see on this picture on the upper right that, of course, the AC joint was injured, like it mostly happens with a direct blow to the shoulder. You have already seen this, and if you have the third talk on AC joints, for sure, this picture has been shown before. I still want to show it because the question is, does the indication follow the classification? And this is the most important question. Does it really help us to find a surgical indication or not? And we will have to answer this later on. This is what Ben Keibler said about this. And I think you all know Ben Keibler, and you know his scientific and sophisticated approach on his questions that he wants to answer. And he has in his paper in 2016, the indications are not well established, and high grade should be operated on, and maybe some of the type 3s. And this shows our dilemma that we were just discussing also in the last talk. This is our reviews from back in Germany from last year. It says that we should look deeper into the subtypes of the Rockwood 3, what the Isocos team did. And this one says that the dynamic horizontal instability seems to be a prognostic factor for worse outcomes. So the question is, do we really have a new problem with this horizontal instability? Is it new to us? If you see this picture on the right side, the upper one, this is what we did the years before. We did maybe an axial view in addition, but we looked at this and said it's a type 1 or type 3, 5. That was enough. Now we do these Alexander views, and you can see that on this Alexander views, the overlapping length is differently, even if this might probably be a type 2 Rockwood lesion. This is horizontal unstable. And we know this already from Fukuda and his colleagues, what types of ligaments stabilize vertically and what do stabilize horizontally. It's different. And this is important for our reconstruction. This is a group from Germany, Dirk Meyer. He showed us in 65 cases of a prospective series how these ligaments, these AC capsule ligaments, can tear. It can tear in 5 different types, diagonally, or it can tear completely in the middle, or it can be torn off at either side. And I think also this is an important study if we want to repair this, if we want to reattach this. Because in some of these cases, if it's really wrapped off the bone, there might not be a possibility to just suture the tissue. Horizontal instability, what are we really talking about? So we were talking about this grade 4, type 4 Rockwood lesion, and for a long time we were talking about a horizontal instability. Of course, this is a horizontal instability, but this is what I think most of the types we don't see. I'm not sure who has seen this in his daily clinical practice. Hands up, please. A locked posterior dislocation of the clavicle. 1, 2, 3, 4. Okay, at least 4. Yeah, I was counting him as well. 4 in the room. it might exist, so we know now it does exist, but this is not what we are talking about if we talk about horizontal instability. Now, I think this is what we are talking about, and this is what Ladoslav already showed. This is an instability following a hook plate removal, and on this video, this is a chronic AC joint instability, and you can see nicely the clavicle sliding over the acromion when he does this adduction test in front of his body. So why does this really matter? Why do we have to think about addressing the AC joint capsule as well? And there is this nice study from Markus Scheibel out of 2014, and he could show that he only addresses the vertical stability, even with two-button systems, like you can see on the X-ray, that approximately 40% of the patients remain horizontally unstable. And at the same time, these patients have lower AC joint-related scores. So yes, it does matter if we don't really look at it and if we don't address this. So the techniques you have already seen, and we can go over this, but these are the current techniques that are out there. And we know they are providing good clinical results. We know even from this study from Tim Sire that the patients can go back to their sports, and they can always also go back to overhead sports and contact sports with a very good satisfaction up to 96%. We have heard about the hook plates, and I just wanted to bring up this slide because it always says, no matter what you do, of course, you can still use the hook plate. Yes, this is right, and it is in use also in Germany, especially in the trauma centers, but there is 2 studies out since last year from Frankfurt, and it's a level 1 study showing significantly better results for arthroscopic techniques, and it was this double button technique, as you can see here, and it shows better sports-related outcomes and a better return to sports following arthroscopic techniques than hook plates. Even if these arthroscopic techniques didn't address the AC capsule ligament. But I think these studies need to be shown when it's about how to fix the acute situations. Why should we repair it? What does biomechanics show us? And there is several studies out. I just brought you 2 of these by Tim Sire again, and the other one by Knut Beitzel, who is in the room. And both of these studies show that if you do not address the AC joint directly at the AC joint with this kind of grafting, or at the upper part with this internal bracing, you will not bring the stability, the horizontal stability, back to normal at all. So this is important to know, and Knut could even show that rotational stability is also dependent on if you do this or not. Another study that I was discussing before is also by the group around August Masoka and Knut Beitzel. They looked at this capsule ligament complex, and they showed that if you want to repair this, you want to suture this, it's better to suture the entire superior part of it, not only the anterior one, because they show difference in strengthening rotational stability and posterior stability. So if you suture it, use a suture more and stabilize the anterior superior capsule, and then you are the most stable you can get over your internal bracing construct. If you want to do this internal bracing, a nice study by Felix Stirner from last year did show that there is several techniques out again, of course, to do so, but it is important that you choose one of these which fit best in your entire technique that you use, and all of these will almost bring your stability, horizontal stability, back to normal or even better. This is the current technique, and I don't know if I should write future technique. We never know. It's the AC joint. This is the current technique that I do use. You can look in this acute case now on the coracoid. You will see the drill hole in a second coming down and a shuttling suture. I measure that I'm really in the middle of the coracoid base, and then you bring in the implant. The second implant is brought up on the clavicle and then knotted. You go underneath the acromion, do 2 drill holes, and then you can shuttle the same sutures down and up again, and then you have this, as you can see here, this cerclage as is shown on the 2 pictures below. If you don't do so, you can see what happens after you fix the cerclage on these lower 2 radiographs. In the first setting, I would say it's not well reduced, this joint. But if you close this AC joint knots together, you can see that the scapula moves towards the clavicle, and you have a better reduction, and I think anatomic reduction of this joint after this final secure. So I think it all comes down to this classification that we talked before. Rockwood, does it really help us? Of course, it still does. We have nothing else. But now we have this Isakos addition to this classification, and I think it's important. If you look at the right side, on the left side, you go down to this type 3B, and patients come back after 3 to 6 weeks. And of course, we can discuss, is it 3, is it 6 weeks? And this discussion never ends. But it all depends on how is the patient doing after 3 to 6 weeks. If he's doing well, he is a type 3A, and he will stay conservative. There is no need to undergo surgery. If he's not doing well, if he still has scapular dyskinesia, if he's still not moving well, he undergoes an radiograph, an Alexander view, and if he's horizontal and unstable, he more likely undergoes surgery. This is what this addition to the classification says, and I think we can stick with this. Of course, we had this problem, and we still have it back in Germany. If we wait for 3 to 6 weeks, we will be in this time frame where we say probably we're going to getting chronic now, and we need a graft in this situation. So maybe we can discuss this later on. This is indication in our daily clinical practice. As I said before, 3A, we will probably not undergo surgery, and then we look at this horizontal instability and want to go back to normal anatomy before using a graft and stay chronic unstable. The most important questions are probably that we need more better studies on this 3A and B, and the questions are how many from the Rockwood groups do need to undergo surgery once they were conservative, and why do they undergo surgery? What are their problems? Are there sports-related problems? Is it pain? And why do some patients, like this guy here, he's really unstable, and I think we can all see this. He's horizontal unstable, and he just came into my office because his friend said, man, you look weird when you climb. You should really go and see a doctor. Okay, he didn't have any clinical problems, and of course, he didn't undergo surgery. Take home, we should be interested in both directions of the instability. The current and correct diagnosis is clinically and radiographic. We should restore CC and AC stability with internal bracing. And, of course, at the same time, we can repair the entire superior capsule ligament complex, and then good luck.